So friends, now let us study the genetic tests which are used for prenatal genetic diagnosis. There are three types of tests: cytogenetic analysis, that is karyotyping; FISH, that is fluorescent in situ hybridization; and CMA, that is chromosomal microarray analysis. Now testing is either performed on amniotic fluid or chorionic villi. First we will see what is karyotyping. Karyotyping is to test chromosomal abnormalities. Any tissue containing dividing cells or that can be stimulated to divide is suitable for karyotyping. Karyotyping detects aneuploidy, balanced or unbalanced structural rearrangements. Its diagnostic accuracy is 99%. What do we do in karyotyping? The chromosomes of the dividing cells are stained with Giemsa stain and are identified. Results come in 7 to 10 days because amniocytes need to be cultured in cell growth media for karyotyping. Second is FISH. Now this is for rapid identification of a specific chromosomal abnormality. FISH is often detected for cases in which findings may alter pregnancy management because it has a turnaround time for 1 to 2 days. As you can see in this, that this is a DNA probe and DNA probe is labeled with a fluorescent dye. It is further denaturated and separated, and the probe is hybridized with patient chromosomes, and fluorescent probe illuminates the chromosomal regions of interest. What are the most common applications? It involves the testing of a specific gene of interest and not the whole chromosomes, used for detecting trisomy 21, 18, 13, X and Y. Third is chromosomal microarray analysis. Now CMA is 100 times more sensitive than standard karyotyping, and it also detects microduplications and microdeletions as small as 50 to 100 kilobases. Direct CMA can yield result in 3 to 5 days. If cultured cells are required, then 10 to 14 days time is required. What are the clinical applications of these three genetic tests? In pregnancies at high risk for autosomal trisomy based on the screening tests, either karyotyping or FISH plus karyotyping should be offered. CMA should be given as a first tier test if fetal structural anomaly is identified. But if a particular abnormality strongly suggests a specific aneuploidy, like for example endocardial cushion defect is significant for trisomy 21, so FISH or karyotyping can be offered as the first test instead of CMA. Third, CMA does not detect balanced translocation, so in patients of recurrent pregnancy loss, karyotyping should be offered. And CMA is more likely to provide a diagnosis in case of stillbirth evaluation. Why? Because it does not require dividing cells. Overall, CMA yields result nearly 25% more often than standard karyotyping alone. Now, what is whole genome sequencing? Now, in some cases with structural abnormalities who have a normal karyotype and a normal CMA result, whole genome sequencing or whole exome sequencing is done. Whole genome sequencing is analyzing whole genome, and whole exome sequencing is analyzing just the DNA coding regions, which account for approximately 1% of the genome. It is done only when CMA fails to arrive at a diagnosis and there is a likely genetic disorder. It is done only with lethal or recurrent anomalies when other approaches are non-informative. The limitation is that it has high turnaround times. Now friends, most important part, what are the prenatal diagnostic procedures? There are three procedures: chorionic villus sampling, amniocentesis and chordocentesis. As we have seen in earlier slides, karyotyping is done for aneuploidy and chromosomal abnormalities, and CMA is advisable in patients with fetal structural abnormality. Now first we will going to study what is amniocentesis. Amniocentesis is the most common prenatal diagnostic procedure. The time with when amniocentesis is done is 15 to 20 weeks, most commonly from 16 to 18 weeks. What are the indications of amniocentesis? Fetal genetic disorders, congenital infections, alloimmunization, and fetal lung maturity assessment. Now, what is the technique of doing amniocentesis? Friends, as you can see in this picture, a 22 to 20 or 22 gauge spinal needle is inserted under USG guidance to identify a pocket of amniotic fluid. Needle is inserted perpendicular to the skin in the area of deepest amniotic fluid pocket, avoiding the fetal parts and umbilical cord. Efforts are made to puncture the chorioamnion rather than to push or tent it away from the uterine wall. Now, the amnion usually fuses with the adjacent chorion by 16 weeks gestation, and the procedure is deferred until after that. Following the procedure, color and clarity of the fluid are documented. Approximately 20 to 30 ml of fluid is then collected for either CMA or karyotyping. Sonography to observe uterine puncture site bleeding and fetal cardiac motion is documented. If patient is RHD negative and unsensitized, anti-D immunoglobulin is given. Now, what are the complications of amniocentesis? There is a pregnancy loss rate of 0.1 to 0.3%, which increases in case of patients with class 3 obesity, that is BMI more than 40 kg per meter square, 1.8% in case of twins, and greater with some fetal abnormalities like aneuploidies and conditions such as hydrops. The other complications with amniocentesis are amniotic fluid leakage or transient vaginal spotting. Now, what is chorionic villus sampling? Chorionic villus sampling is done from 10 to 13 weeks. What is the primary advantage of villus biopsy? That the results are available early in pregnancy, so decision can be taken earlier. Technique is that the chorionic villi are obtained transcervically or transabdominally. As you can see in this picture, transcervical chorionic villus sampling is performed by a catheter which is made from flexible polyethylene with a blunt tip malleable stylet. The transabdominal is performed using 18 or 20 gauge needle. With both the techniques, transabdominal sonography is performed to guide into the chorion frondosum. As you can see in this sonographic picture, the catheter is going inside the placenta. And it then followed by aspiration of villi into the syringe containing tissue culture media. Now, what is the relative contraindication? Vaginal bleeding or spotting, active genital tract infection, extreme uterine anti or retroflexion. Again, anti-D should be given if the patient is Rh negative. The complications are loss rate is more, that is 1 to 2%, and specific side effect complication is limb reduction defects and oromandibular limb hypogenesis and sometimes vaginal spotting. Now, what is fetal blood sampling? Fetal blood sampling is also called as cordocentesis or percutaneous umbilical cord sampling. What is the most common indication of fetal blood sampling? It is the fetal transfusion of RBCs in anemia from alloimmunization and the assessment of fetal anemia. It is also performed for the assessment and treatment of platelet alloimmunization and also for fetal karyotype determination. What is the technique of fetal blood sampling? It is done under direct ultrasonographic guidance by insertion of 22 or 23 gauge spinal needle. As you can see in this picture, the needle is inserted directly into the umbilical vein and the blood is slowly withdrawn into the heparinized syringe. Now it is inserted at the placental cord insertion site or if a free loop is identified. Arterial puncture is avoided because it may result in vasospasm and fetal bradycardia. After the needle is removed, we check for cardiac activity and site for bleeding. What are the complications? The fetal loss rate is more, that is 3.4%. Others are cord vessel bleeding, fetal maternal bleeding and fetal bradycardia. Now friends, we studied what was prenatal genetic testing. Now what is pre-implantation genetic testing? Something which is new for us. For couples undergoing IVF, Genetic testing is performed on oocytes or embryos before implantation. This provides information regarding the chromosomal complement and single gene disorders. It is of two types: pre-implantation genetic diagnosis and pre-implantation genetic screening. Now, there are three techniques which are used for both these categories. First is polar body analysis. In polar body analysis, first and second polar bodies are extruded from the developing oocyte following meiosis 1 and 2. Now, this is only for maternally inherited disorders. So, genetic abnormalities of paternal origin are not detected. It is used to diagnose Mendelian disorders and has 99% accuracy. Second is blastomere biopsy. Now, this is done at 6 to 8 cell stage when an embryo is 3 days old. This allows both maternal and paternal genomes to be evaluated. One cell is removed from the zona pellucida. What is the limitation? Due to mitotic non-disjunction, mosaicism of blastomeres may not reflect the chromosomal complement of the developing embryo. Also, implantation rate of developing embryo is slightly lower after the procedure. Third, trophoectoderm biopsy. Trophoectoderm biopsy is 5 to 7 cells taken from a 5 to 6 day blastocyst. What is the advantage of trophoectoderm biopsy? That because the trophoectoderm cells give rise to trophoblast, there are no cells which are removed from the developing embryo. And the disadvantage is that procedure is performed later in development. So if genetic analysis is not done rapidly, then we need to do cryopreservation and embryo transfer for later IVF cycle. Now, what are the two types of procedure? One is pre-implantation genetic diagnosis. Now, this is done with the known carrier of a specific genetic disease or a balanced chromosomal rearrangement. PGD may be performed to determine if an oocyte or embryo has that defect. What are the applications? It is done for cystic fibrosis, beta thalassemia, hemophilia, to determine gender in X-linked disorders and mutations like BRCA1, and to match human leukocyte antigens for umbilical cord stem cell transplantation for a sibling. What are the risks? That there may be a failure to amplify the genetic region of interest. Sometimes there can be a selection of a cell that does not contain a nucleus, and there can be maternal cell contamination. Infrequently, affected embryos thought to be normal are implanted, and unaffected embryos are misdiagnosed as abnormal and discarded. So, American Association of Reproductive Medicine suggests that further prenatal genetic testing should be done to confirm the diagnosis. What is pre-implantation genetic screening? This is again an aneuploidy screening on oocytes or embryos before IVF transfer for those who are not known to carry a genetic abnormalities. But what are the disadvantages? Mosaicism is common and pregnancy rates are lower. Thank you friends. If you have any doubt, kindly write me in the comment section and like and subscribe my channel for more OBGY updates.